This webcast and any accompanying materials are copyrighted by the American Association for Respiratory Care. Any public display, sale, copy, or distribution of the video or materials may only be undertaken with the prior written consent of the AARC. Copyright 2014, all rights reserved. My name is Shauna Strickland. I am a respiratory therapist, certified asthma educator, and Associate Executive Director at the AARC. I welcome you to today's presentation, Pharmacologic and Other Support Aids for Tobacco Cessation. Upon completion of this AARC webcast, participants will be able to become familiar with the benefits of quitting smoking at any age, become familiar with the pharmaceutical agents used to quit smoking, including how they are used and what are their side effects, and know which populations are particularly likely to be smokers. I am pleased to welcome Dr. Steven Schroeder. Dr. Schroeder is a professor in the Department of Medicine and the director of the Smoking Cessation Leadership Center at the University of California, San Francisco. The Smoking Cessation Leadership Center works to narrow the gap between what health professionals should do to help smokers and what they actually do. Dr. Schroeder has published a great deal with regards to tobacco dependence and cessation. He also holds a distinguished professorship in health and healthcare at UCSF. Neither Dr. Schroeder nor I have conflicts of interest related to this presentation. Any use of images or brand names is not in any way meant to be an endorsement of a specific product, but to merely illustrate a point of emphasis. Dr. Schroeder, welcome to the program.
Thank you, Shauna, and it's a pleasure to speak to respiratory therapists who perform such an important function for smoking cessation at so many institutions across the country, including here at UCSF. So let me go through a whole number of slides that will illustrate the importance of smoking and try to both motivate and inform you so that you can help smokers quit. So on this next slide is a 50-year span between the landmark publication of the Surgeon General's report on smoking and health in 1964 and its update in 2014, both of which demonstrated how much smoking contributes to illness. The Journal of the American Medical Association on January 8, 2014 put together an issue that contained a great number of articles about smoking and how it's harmful, and it has this very colorful cover, including a picture of Luther Terry, the Surgeon General in 1964, who was the author of that report. Here you can see my conflict of interest, which is basically that I have none, although our center does work with Pfizer to pass through $4.5 million in grants, but we receive no payment for this effort. So today I'm going to talk about facts about smoking and health, the epidemiology of smoking, how to help smokers quit, and then next steps. So let's start with the facts, which are still grim. Almost 500,000 deaths every year in the United States, almost 5 million worldwide each year, 10 million deaths estimated across the globe by the year 2030 if current trends keep as they are. About 42,000, actually the number came down a little bit, in the U.S., deaths in the U.S. are due to exposure of secondhand smoke to non-smokers. In addition to those 500,000 deaths, about 16 million people in the United States have illnesses caused by smoking. These include things like emphysema, lung cancer, heart disease, and stroke. There are about 45 million smokers in the United States today. About 4/5 of them smoke every day, and that averages about 13 cigarettes per day, and about 22% are non-daily smokers. And how do smokers who smoke die? Well, smoking is an equal opportunity killer, but you can see it's from cardiovascular diseases, lung cancer, respiratory diseases like COPD, secondhand smoke, and the numbers vary from year to year, but the ballpark hasn't changed much. Cancers other than lung, and then the last category is other. This is one of my favorite slides because I keep updating it every time there's a new study to show that smoking increases the odds ratio of getting these illnesses. So I won't read all of these. You'll have access to all these slides, but the yellow words are ones that I've added in the last year or two. For example, men with prostate cancer who smoke die faster than men with prostate cancer who don't smoke. People who smoke are more likely to get TB, type 2 diabetes, children who are exposed to secondhand smoke or whose mothers smoke are more likely to be overweight. We're going to have a webinar in 2 weeks showing that smoking increases the risk for Alzheimer's and also rheumatoid arthritis and insomnia or other sleeping disorders. So a lot of things from smoking. And you often get asked, well, doc, is it too late for me to stop smoking? Isn't the horse out of the barn? And the answer is no, as you can see from this and subsequent slides. Circulation gets better in 2 to 3 months. Now, one of the things that happens when you stop smoking is that your cilia come back. And a lot of smokers have a lot of mucus in their bronchial tree, more than normal. As the cilia come back, they sweep more mucus out. So people who stop smoking may actually cough more, find it more productive, and wonder if that's because they stopped smoking. The answer is yes, it is, but it's a healthy sign. Within a year of stopping smoking, your risk of coronary heart disease is down to about half of that of a continuing smoker, and within 15 years, you're down to the risk of someone who's never smoked. Similarly, within 5 years, your risk is down to that of a never smoker. Unfortunately, you never get your lung cancer risk down to a never smoker, but within 10 years, it's down to the risk of someone who kept smoking. And this was an article last year to show the years of life saved from stopping smoking. And from age 65 on, although it wasn't in that paper, you save a couple of years too. So it's never too late to quit smoking. That's the message. Mental illness imposes, smoking and mental illness impose a particularly heavy burden. Of the almost 500,000 deaths from smoking, about 40% of those occur among people with chronic mental illness and or substance use disorders. This population consumes about 40% of all cigarettes sold in our country. That's a function of the fact that they smoke more. They have a higher prevalence of smoking. They also smoke it right down to the butt. This population dies earlier than others, and smoking is a major contributor to those early deaths. So people who are alcoholics, who are using heroin, who have mental illnesses, they die more from their smoking than from other things. They're at greater risk for withdrawal from the nicotine, and they also have it more difficulty getting back into wellness because the stigma from smoking tends to isolate them. So that's the harm that smoking causes, and I could have gone on for a lot longer time, but in the interest of time, we're going to switch now to epidemiology of tobacco use. On this slide, you can see that in the mid-1950s, there was a major gender gap between men and women. It's a very smart marketing campaign which said, "You've come a long way, baby," selling Virginia Slims. That gap narrowed, and it's now pretty small. And as of the year 2013, 18% of adults were current smokers. And of those, 70% want to quit. Now, this is another version of that slide showing in the blue line average smoking rates for both genders. And you see that they came down pretty steeply in the 60s and 70s, and the fall off has been more gentle, but still in the right direction since. It used to be thought that when you got rid of smokers, you'd get rid of the easy ones. So it was the low-lying fruit. And the residue would be hardcore smokers. If that were true, the average pack of cigarettes per smoker would have gone up. But in fact, that didn't happen. Between 1965 and 1995, those who continued to smoke smoked about a pack per day. And those who, and then beginning in 1995, the average rate of smoking, the average number of cigarettes per day among smokers went down to about 13. And that's a function of a lot of public health measures, including raising the price of a pack of cigarettes and clean indoor air laws. So this is really good news. As opposed to my parents' generation, and you can see from my photo that I'm not a young guy, in that era, smoking was thought of as pretty sophisticated, and many smokers were in the upper social class. That is no longer true. And if you look at education as a marker for class, you can see that only 5% of those with graduate degrees smoked, and up to 25% of those with who didn't graduate from high school. You'll notice at the higher bar, 45% is among people who got their high school GED. And that occurs a lot in prison. And many people in prison are there for substance use disorders such as alcohol or drug use. So in that issue of JAMA, January 8th, 2014 that I showed you, there's an article by Holford that reviewed benefits of tobacco control in the United States over the almost 5 decades since the first report of the Surgeon General. And they showed that during that time, almost 18 million smoking deaths occurred. But 8 million such deaths were prevented. And that 30% of the major gains in life expectancy during that period were preventing smoking-related deaths. And then the article by Cook pointed out that people with mental illness do not benefit nearly as much from those declines in smoking rates. Some of you are going to be asked about covered benefits under the Affordable Care Act, and you'll see that 4 counseling sessions of at least 10 minutes each are covered, including telephone, group, and/or in person. That all FDA-approved smoking cessation medications, including both drugs that you need a prescription for and over-the-counter, such as the gum and the patch, are covered. That this can be offered at least twice yearly. No prior authorization is needed. No co-pays, no co-insurance, or a deductible. But I must say that implementation is confusing, and that many insurance companies don't understand what's going on, and the implementation can be piecemeal. So let's turn to smoking cessation. How can you, as respiratory therapists, help smokers quit? Now, this is a slide that was published in that same issue as a research letter by Linda Sarna, who's a nurse at UCLA. Her figures for physicians are a little bit higher than other surveys. Most surveys show that doctors have a rate of 1%. Nurses, which used to have really high rates, are down now to 7% from almost 25% a few years ago. LPNs, 25%. Pharmacists, I've seen data that they're 4%. Respiratory therapists, I was told when I first began working with AARC that you all have a rate in your 20s, but that's no longer true. It's down to 10%. So if the whole population smoked at the rate of health workers, minus LPNs, we would be much healthier as a society. Smoking is a 2-part problem. One is a dependence that's physiologic, and one is the link to personal behaviors and the cues. And so successful smoking cessation works on both of those aspects. The 5 A's are the sort of the Bible, and you can see in the upper right-hand corner, treating tobacco use and dependence. This is a public health guideline. It's by Fiore et al., and the reference to it is down at the bottom in the yellow script. And the 5 A's you can see there: ask about use, advise to quit, assess readiness to quit, assist with the attempt, and then try to make an arrangement for follow-up care. There are measurements of smoking intensity, and probably most of you won't have the opportunity to do these, but you should know of them. One is the Fagerstrom test, which is a 10-point questionnaire, and I'll show that in just a minute. And the other are biochemical markers. One is to test cotinine, which is a major breakdown content of the nicotine that is such a major part of smoking. And the other is carbon monoxide, which you can test with a breathalyzer. And the parts per million in non-smokers are 1, 2, or 3, and the parts per million in smokers range from 10 to as high as 90 or even more. This is the Fagerstrom questionnaire. Without going through all the 6 items, you notice that it can sum up to a total of 10 points. And the major points are, when do you have your first cigarette? So if there's only one question you have time for, that's the critical one. And the earlier they smoke, the more likely they are to be hooked. Hard to refrain from smoking if smoking's off limits. Which ones would you hate most to give up? First one, daily cigarette smoking frequency, etc. Nicotine is absorbed in the stomach. Alkaline media makes it more absorbed, which is why the makers of cigarettes make it more alkaline so that you can get more of the nicotine absorbed in your body to go to the brain. And this shows that a cigarette really is a nicotine delivery device. Within minutes, within seconds actually, your brain gets smoking, gets the drug from the arteries, and that stays up for many, many minutes. So it's an efficient delivery device. What does nicotine do? Well, people like it. In the brain, it makes you feel good. You can maybe you can concentrate better, do tasks better, be less anxious. Other things it do is it suppresses your appetite, stimulates your rate of what you're doing, it relaxes skeletal muscles, and stimulates the cardiovascular system. So it revs you up. And this is a nice cartoon to show that when nicotine enters the brain, it stimulates the dopamine centers, the nicotine receptor centers, in the 2 areas, nucleus accumbens and ventral tegmental area. When the nicotine stimulates those centers, it releases dopamine. Dopamine goes to the prefrontal cortex, and it makes you feel good. Similar pathways occur with alcohol, with cocaine, with sex. I think for me, when I hear Beethoven, so it's a common pathway, but this explains why it's so hard to give up smoking, because it brings pleasure. When you withdraw from nicotine, I'm sure many of you who have friends who've tried to stop, and it's not a pleasant time. And you can see from all these symptoms that it makes people irritable, less fun to be with, less good at their jobs, and the comment often is, "Oh my gosh, Tom or Lucy, I liked you better when you smoked. Please go back on it." But the good news is those symptoms get better over time, so be sympathetic. And this just shows that smokers titrate to keep their nicotine within an acceptable bound, the band that's in darker colors, to keep their levels of the nicotine at an acceptable level. Now, I'm amazed how many really smart friends I have who think it's the nicotine that causes cancer and other illnesses, and therefore giving the gum or the patch is going to make people sick. Well, as you can see here, that's not true. It's the other 7,000 chemicals, the carbon monoxide, and other things that make you sick. So how can you quit? Well, under the behavioral strategies, there's cognitive strategies, which is basically to make the case why smoking is bad for you. And this is an individual thing, so you got to find out why smokers quit and kind of motivate them to avoid the stress areas, to figure out why their lives are going to be better. It may be to go to their daughter's wedding, it may be to see their granddaughter graduate from high school, but there are lots of different reasons, and imagery can be helpful. There are strategies to avoid the stress. Alcohol is one very seductive. Alcohol, the first morning cup of coffee, people often automatically light up. So if you can cue them into not lighting up at those times. In California, bars are now smoke-free, and that's been a real stimulus to help people stop smoking. If the smoker's good friends or spouses or partners smoke, that's really hard. So you can work with their spouses and partners to see if they can at least smoke outside the house, but maybe even stop smoking. move the ashtrays out, all these sorts of cue things. Oral gratification substitutes, anticipate the automatic smoking routines. You're going to be asked a lot about weight gain. Women in particular are very sensitive to this, and it is true. The average, and it varies, but the average person who stops smoking gains 8 to 12 pounds. You can delay that weight gain by using gum or bupropion or by exercising, but you are going to gain weight. But fortunately, you'll be able to exercise better, and most of that weight falls off. Social support is really critical, and one of the things you can get the patients to do is to talk to their friends and colleagues, tell them the venture they're going to go on and how hazardous that's going to be, and ask them to give you as much support as possible. And of course, telephone counseling or group counseling can be very, very helpful too. So let's go on to pharmacotherapy, and up on the right there you see that same guideline. So the best way to increase your odds of quitting are to merge counseling and smoking cessation medications. So let's look at first-line therapies. There are 3 general classes of FDA-approved drugs to help smokers quit. 5 are nicotine replacement therapy. The gum, the patch, and the lozenge, all of which you can get over the counter, the nasal spray, and the inhaler for which you need a prescription. Then there's a partial nicotine receptor agonist, varenicline, which is marketed by Pfizer's Chantix, and psychotropic sustained-release bupropion, which is used as an antidepressive, and in its brand form, it's used as Zyban to help smokers quit. So I'm going to briefly go through these 7 forms. The gum might satisfy oral cravings. As I said, it might delay the weight gain. Comes in both 2 and 4 milligram strengths. The 4 milligram strength helps better to delay the weight gain. The advantage is patients can titrate it. That is, they can chew when they get the urge to keep smoking, and so that's helpful. And you get them in a variety of flavors. The disadvantages are the need for frequent dosing can compromise the patient compliance. In people like me who've had a lot of dental work, it can wreak havoc with them. Patients must be taught you don't chew it like a chiclet. You chew it a couple times till you get the ting, and then you park it in your cheek until you get the urge again. And in a lot of social situations, gum chewing isn't socially an acceptable thing to do. Although, if you noticed, in 2009 in January, President Obama was chewing his gum on the reviewing stand. So this just shows, I won't go through it, but this just shows you the cycle of how to use it. And I'll pause for a minute and let you read this. And the caution is don't eat or drink 15 minutes before or after using it. Partially that's because the things that you eat or drink make your mouth more of an acid nature. And as I mentioned, nicotine is better absorbed in alkaline solutions. So that's used to combat urges. The nicotine patch is probably the mainstay of the drugs because you slap it on, it gives you a constant drip, drip, drip of the nicotine levels. It doesn't give you that pulse that I showed you with the previous graph, but it gives you nicotine levels. It comes in 3 strengths. You slap it on in the morning. It's easy to use. Nobody knows that you've got it on, so the compliance is good. The problem is you can't titrate it, so it's often used in concert with the drug, with the gum or the lozenge. You can get an allergy to the patch, but you can take care of that with over-the-counter hydrocortisone. And if you've got a severe dermatologic condition, you probably shouldn't use it. The lozenge is similar to the gun in how it's used. It's not as commonly used, and I think that's because it has a higher rate of GI side effects, nausea, hiccups, and heartburn. The nasal spray is, again, not used nearly as often as an NRT form as the gum or the patch. People use it, they titrate it like a cigarette. They get nasal and throat irritation sometimes. And if they've got chronic problems with their sinuses and all, it's probably not a good thing that ought to be used. And remember, you need a prescription for this as well as a nicotine inhaler. People who use the inhaler like it because it mimics what you do to be a smoker, the hand-to-mouth ritual. But again, it's not used as often. We'll come to the e-cigarette later. That's probably the thing that's closest to the inhaler. And if you've got asthma, you probably shouldn't use this. So this is probably the most controversial of any of the medications used to help smokers quit. It's controversial because it looks like it works, but there's a risk of side effects. So this is a designer drug. It's a partial nicotine receptor agonist. The early trials and subsequent use have shown it's probably the best stand-alone drug of any of them. And the way it works is because it partially occupies the nicotine receptor, that is, it's a partial nicotine agonist. When you smoke, you don't get as much buzz from the hit of the nicotine, but also you don't get as much craving because it's partially activating that receptor. The most common side effect is nausea. The mechanism of action, as I mentioned, is that it gives you agonists, and you get less withdrawal, and you also don't get as much of a hit from smoking. This is how you use it. You start while the patient is still smoking, and you start with a lower dose and work gradually up to minimize nausea, so that by day 8 you're on the twice-a-day smoking rates, drug rates. The advantages are that it's easy to take it twice a day. It hits the receptor site that keeps people as an addict to the nicotine, and it probably is the best stand-by-itself agent. The nausea I mentioned, most people tolerate that, so very few people have to quit using the drug because of the nausea. They get better from that. But here's the big but. There have been cases of people trying to commit suicide, and some who actually did it. There have been probably now several hundred reported suicides since the drug came on the market. There have been about 8 million prescriptions of this that have been sold. And we don't know whether those suicides are a function of the fact that many people who smoke have chronic depression, that withdrawal from the nicotine from smoking makes people more depressed, or whether it's the pharmacotherapy itself. We really don't know that. When the nicotine patch came on the market, there were similar things. Since the time the black box warning came on by the FDA, it looks like this is less of a problem than we knew. Pfizer's been asked to do more drugs, but there's no way they do more drug trials, but there's no way that they can study a sufficient number of patients to really see if this is one of these extremely rare but very serious side effects. Similar things were seen in a meta-analytic study in the Canadian Medical Association Journal of cardiac rhythm problems. Subsequent data haven't borne those out. So this just shows you that in July 2009, both Chantix and Zyban were put into a black box warning. Pfizer did settle suits regarding suicide for $288 million. They didn't acknowledge blame, and it's unclear whether they did that because they thought there was a risk or they just didn't want to have the risk of the suits that were hanging over them. So my sense of this is that if you have a patient with mental illness, you probably shouldn't use should not use varenicline as a first-line agent, but since it does work, it may be a fallback one. Bupropion is the last drug that I'm going to mention. It was found serendipitously that people with who were using it as an antidepressant tended to have a lower craving for cigarettes. And so it was tested separately, and it turns out that it worked. And nobody knows quite how it works, but it works sort of similar to Chantix in that you crave cigarettes less and you get withdrawal less. Again, you start this prior to the patient quitting smoking and build up to twice daily usage. The advantages are just like the other pill. It's easy to use. You can use it twice a day. No one knows if varenicline can be used in combination with NRT, although there are some trials going on now. bupropion can, and it probably enhances the rate of quitting. And it may be useful for patients who are clinically depressed, and it might delay weight gain. The one big risk is if people have a seizure disorder, it will increase the risk of seizures, not by a huge amount. In the lower right-hand corner, you see a lot of things that will increase the risk of seizures, and so these people are probably best advised not to use it. Combination therapy is often used in those places that see a lot of smokers. Commonly, this is a long-acting form of NRT, the patch, a short-acting form, one of the other four, often in combination with bupropion, and whether varenicline in combination with other drugs works isn't clear. But particularly those patients who find it hard to quit, pack a day or more, probably it's better to use a combination therapy. What the Mayo Clinic does is it titrates the number of patches, 1 pack a day, 1 patch of the 21 milligrams, 2 pack a day, 2 patches of 21 milligrams, plus the gum, plus bupropion. I'm not going to read this. You'll have access to it, but this is a nice look. It's sort of a compare with all the 7 versions of drugs, and you can print it out and use it. Under the Medicare coverage, we mentioned that smoke cessation medicines are prescribed by a physician. The Affordable Care Act may have trumped that, but there's a lot of confusion as to what exactly is covered on smoking cessation. So you may find that you've got to go and talk to the health insurer on this, which I know takes a lot more time than you want to do. And I talked about that previously. Now I'm going to show next a summary slide of all the different medications compared to counseling by itself. And these are this is a Cochrane collaborative from all the published drug trials. But I want to caution with some caveats. One is that smoking should be thought of as a chronic condition, and yet drug treatment by the FDA often says 12 weeks. I think it's certainly very responsible to treat much longer, particularly if the patient says they will relapse if they keep smoking. Secondly, smokers vary incredibly much, so you can't just do a cookie cutter, and you got to understand the habits of each smoker. The third is that all the volunteers for those studies were very much more of a motivated cohort. They had to come to a lab to get blood and urine tests, so they were not your run-of-the-mill smokers. So the results are likely to be more favorable in this group. Finally, both the placebo and the drug arms had intensive and excellent counseling, probably better than what's found in the real world. And finally, most drug trials exclude patients with mental illness. So what you see here are probably in general higher rates than found in the real world. And I want to make 3 comments. One is that for each of the medications, you can see that using the medication with counseling gives you higher rates, and that's in the yellow bar, than counseling by itself, which is the blue bar. Secondly, as I mentioned, that all these rates are higher than cold turkey, and that's probably because the counseling is so much better, and the drug arm too. And third, you really can't compare each one, because you can't compare, for example, the nicotine nasal spray with the lozenge, and we don't have the results of drugs in combination. But you get the idea here that the patient's chances of quitting are better. Still, the sad thing is that at least 3/4, if not more, of the patients in these trials were not able to quit after 6 to 12 months. This is an exciting paper that's 15 years old, but that showed rates of almost 1/3 of smokers able to quit with the patch and bupropion. Clinicians can increase the rate of quitting. Physicians, the highest rate, increase the odds 2.2, but respiratory therapists can. But if you think that giving a brochure is going to help, you're kidding yourself and the patient, because the data don't show that they do any help at all. So you're going to see a lot of patients who are light smokers. About 22% of all smokers don't smoke every day, or and an even larger number smoke only 2, 3, 4, 5 cigarettes per day. The drug trials usually had 10 to 15 cigarettes per day as the entry price. So we don't know whether smoking cessation medications work for patients who smoke, say, on a small basis. And generally, they're probably not as hooked to the nicotine, or they wouldn't be able to get away with smoking so few cigarettes. So it's important to get their history and see whether drug treatment is going to be useful. Often for them, it's social cues. So you try to find out why is it that they smoke. We don't know why they're so concentrated among young adults, but we think it's the bar scene maybe. And we don't know whether over-the-counter access to getting the gum or the patch in the absence of advice from the clinician may make them less potent. So the Joint Commission has advised that that smoking cessation will now be one of 14 measures by which a hospital can select 4 to qualify for Joint Commission mandated core measure measurements. It turns out that the first 4 bullets, assessing tobacco use, providing or offering treatment, checking on post-discharge use, and ascertaining post-discharge smoking cessation status, has not been a popular option for most hospitals. Only about less than 100 of the 5,000 or so hospitals have taken those up. But the National Quality Forum has said they're interested in doing this. CMS is beginning to think about it. So it may be that your hospital by 2015 or 2016 will actually be at risk of losing money if they don't do this, in which case you're going to be called upon, many of you, to be the hospital's arm to activate these regulations. So my advice is, if you're not doing it now, stay tuned. So what about telephone quit lines? Telephone quit lines are available in every state. They're no cost. They're staffed by trained specialists. They offer up to 4 to 6 personalized sessions every day for every smoker. Varies by state. Some of the state quit lines, including California, offer vouchers for those who've completed these counseling session, which can be as long as 40 minutes, and it's individually tailored, at either no cost or low cost. And the success rate of quit lines is comparable to counseling. So you should get fax to quit line forms. In many states there are cards. We offer a blue card, Smoking Cessation Leadership Center. We make them available at cost. You can contact us and we'll connect you to the person who makes them. They cost about 10 cents each. They are a plastic card that I tell patients to put next to their credit card, and they really work. There are about 5,000 of them in circulation. This shows you a Cochrane study of the odds ratio of quitting using NRT. Odds ratio is 1.74, 1 meaning no use, twofold meaning a twofold rate of quitting. You can see the telephone counseling is comparable to NRT with an effect size of over 1,000 patients, you can see in the lower right-hand corner. So telephone quit lines, evidence-based, is good that they work, but unfortunately, in California, which has one of the best ones, only 4.5% of smokers knew of them, and in most states, with the exception of the state of Maine, less than 3% of smokers use a quit line. So this is an under-resourced, wonderful way to help smokers quit, and it doesn't take you very long to work with the patient to urge them to do it. You can see when the CDC had their Tips from Former Smokers campaign, Legacy Foundation showed that calls to the quit lines nationally soared. And there are going to be campaigns in the next year, in 2014 actually, from Legacy, from the FDA, and from the CDC. So again, you'll have access to all these slides. Online smoke cessation assistance is also there. Patients love quit lines and using online version because many of them are really embarrassed that they smoke, and when they go to a clinic they have to fess up, and when they don't, when they use a quit line, there is anonymity. And you can see that the Quit Now, smokefree.gov and becomeanx.org, all show ways that you can connect up to a web base. So I think we're going to have time for questions. I'm now going to move to my end slides and the next steps. One, a number of you are going to ask about the e-cigarette. I'm going to try to do a preemptive strike here, but the basic bottom line is we don't know. What we do know is that more and more people are using them, that they're being marketed. They're being marketed very seductively. They're being bought out by the industry. So the Philip Morrises and the R.J. Reynolds of the world are buying out these products, that they aerosolize nicotine in a propylene glycol solute, that the technology is in evolution. So they're getting first, second, third, and probably soon fourth generations. They're getting more efficient at delivering nicotine, but right now they probably give less than people think. We don't know how safe they are, but they are probably a heck of a lot safer than a combustible cigarette. We again don't know whether they can help smokers to quit or whether they really prevent people who want to quit smoking from quitting. They're not approved by the FDA. We don't know whether they're a bridge device for starters for young people. And we don't know how harmful they are to youth. So my advice to smokers who want to use the e-cigarette is they're not as safe as stopping smoking. They are safer than keeping smoking. The exposure to secondhand smoke is less than the exposure to a combustible cigarette, but we know that they're not totally safe. So tips for your practices: get referral forms to the quit line, and you can get connected to your local state quit line by dialing 1-800-QUIT-NOW. If you can afford a carbon monoxide breathalyzer, they're handheld devices. They're expensive to buy, $500, but then they last a long time, and you use a disposable cardboard mouthpiece, which is very cheap, and you can breathe into them and see how many parts per million of CO the patient is exhaling, and they're wonderful for a patient to titrate. To recapitulate, the best question to ask is, when do you have your first cigarette of the day? And approach smoking as a chronic illness. So you don't think that most diabetics are going to get cured. If you can cure some of them or cut down on their HB, on their glycohemoglobin level, that's a triumph. The same thing you should think about with cigarettes. And the good news is that smoking rates are going down. Here in California, our rate is only about 12%. Our modern prevalence level is now at an all-time low of 18%. Those who continue to smoke fewer cigarettes. Physicians are only smoking about 1% rate. CVS Caremark and hopefully the other retail chains have stopped selling cigarettes. That'll happen as October 2014. In addition to secondhand smoke worrying, now certain places, San Diego and elsewhere, are looking at all the pollution from cigarette butts as an issue. So just the constraints are rolling in. Under the ACA, insurance companies can charge higher premiums for smokers. It costs more to buy a pack. Finally, lung cancers and deaths in women are starting to fall. There's characteristic of a lag period between when rates go up and then lung cancer rates go up, and then 30 years later, as rates go down, lung cancer rates go down. Lung cancer rates in men have been coming down for a long time, but just coming down for women. Smoking is more stigmatized. I feel bad about that for the smokers, but it sends a clear message that smoking isn't normal. One of the things we worry about with the e-cigarette is it might glamorize it. I mentioned the 3 different mass media campaigns that will be rolling out this year. And because the tobacco industry was held to violate essentially the mafia law of RICO because of their practices, they now have to issue and publish corrective statements for newspapers on their previous bad conduct. It'll really be fascinating to see how they phrase those. So, final slide. Of the 43 million smokers, about a third to probably closer to half will die from their smoking. 70% of them want to quit. So 0.7 times 43 million is 30 million. Of those 30 million who want to quit, 10 to 15 million will die from smoking if not able to quit. Increasing the 3% baseline smoking cessation rate to 10% would save an extra million lives. If the cessation rates rose to 15%, we'd save 1.5 million lives. No other health intervention, that a respiratory therapist or a nurse or physician could do to make such a difference. And I'm just thrilled that you all have tuned in, over 400 of you, to try to do better in this function. So, Shauna, let's go back to you for questions.
Thank you so much, Dr. Schroeder. This has been really enlightening for me. And we have a lot of really great questions and comments. One that's a really simple, I'm hoping a simple question for you, because I have no idea. You know that you said that e-cigarettes have 20 milligrams of nicotine per cartridge. About how much nicotine is on the average in one cigarette?
Well, there's 20 milligrams in a cigarette, but you only inhale about 1 milligram.
Okay.
So it's thought that nicotine, if it's working well, it'll give the equivalent of 1 cigarette.
Okay. So,
but again, I should just clarify. This is, each device differs, and it's a moving target.
Okay. So going back to the beginning of your presentation, you talked an awful lot about the 4 counseling sessions that are reimbursable under the ACA. Is there a stipulation on who or what kind of healthcare provider can provide those counseling sessions?
Well, I anticipated that question and asked the folks at UCSF, and respiratory therapists are billing over $100 for that counseling session here at UCSF.
Fantastic.
Yep.
So we're going to move on. The next question is about the prescription and over-the-counter products.
Yep.
Do you feel that the side effects that these different products may come with have been underplayed in popular media or in prescriptions?
I think they've been overplayed. I think the popular media, one of the things you have to know is that most of the elite in this country, I was just at my class reunion for med school, and I basically I did a show of hands. How many of you had parents who smoked? Everybody raise your hand. How many of you smoked in college? Most raise your hand. How many of you have children who smoked? Nobody raise your hand. We don't know anyone socially who smokes. Nobody smokes in our house. None of our friends smoke. So the elites who write about this are basically living in a gated community. And so what they see, they think of their friends who, if they started these medications, might get a side effect. They really have to think of what's the trade-off between keeping smoking and going on to these meds. That's a long answer, but I think it's a sophisticated question, and I wanted to give it ample coverage.
So we're talking about, the next couple are talking about insurance coverages. When we talk about the insurance coverage for prescribing a drug to quit smoking, do we see more likely the insurance companies will pay to get the drug prescribed for depression versus smoking? Or is it a mix? Is it even an issue with insurances?
Oh, it's a huge issue, and I can't give a global answer because there's a different state program for all the Medicaid programs. There are 51 of them, and there are a whole number of private health insurers. And even if you have, say, WellPoint or United, you may have one of sort of multiple products. So there's no simple answer. And as long as you specify the use, since bupropion is not an over-the-counter medication, you should get equal coverage whether you prescribe it for psychiatric use or for smoking cessation.
Moving on to other methods of helping people quit smoking, is there any data to support the use of a cold turkey method plus counseling?
Sure. No, counseling isn't cold turkey. So cold turkey means you do it by yourself without anything, maybe some attaboys from your friends, and that's a rate of 3 or 4%. as you saw in the placebo arms, the blue bars of the Cochrane thing, good counseling gives you quitting rates of up to 10%. And the quit line can give you rates up to 10%. So counseling is it's very good, and it increases the odds of smoking.
What about hypnotism? That's a popular alternative therapy. Is there any study that tells us that that's a viable quit option?
So the public health guideline that I showed you, the white cover or the blue cover and the white writing, reviewed all the things, hypnotism, acupuncture, and found that there were no good studies. So they didn't put them as a recommended, scientifically validated study. On the other hand, there are anecdotes. And I have friends who, when many of my friends were smoking, quit with hypnotism, with acupuncture. So if a patient wants to try them, have them try it, but tell them if it doesn't work, please come back to me and let me try you with counseling and one of the medications.
One of the other participants was curious about using the carbon monoxide breathalyzer because this person had indicated that there are several people who are dishonest about smoking habits to avoid higher insurance premiums. And we do know that there are some employers now who have changed their hiring practices to not hire people who smoke to decrease those premiums that they have at their place of employment. Do we know of anyone who is using the CO breathalyzer to double check this, or are we taking people at their word?
That's a great question, and it's interesting that the hallmark of companies that are saying we're not going to hire are hospitals and healthcare systems. The Cleveland Clinic, Geisinger, University of Pennsylvania Medical Center are all saying those are our people. They put into effect smoke-free policies the last couple of years, and they basically said, if you're already smoking, we'll help you to quit, but we won't hire new smokers. As far as I know, they've all been on the honor system, but if a boss smells the telltale signs, they're at risk for getting fired. But we're not yet doing a police state of having them pee in a cup and measure if there's cotinine in there or having them use a breathalyzer.
One of the participants wondered if Wellbutrin was still being used as a smoking cessation aid.
That's the same as Zyban or bupropion. It just has 3 different names. So Wellbutrin and bupropion are the same kind of a generic drug. For some reasons, one is used, the Wellbutrin as a generic for antidepressant, bupropion as a generic for smoking cessation. Same drug.
And
actually, maybe Wellbutrin is the brand name for the antidepressant, but it's the same drug.
Thank you. One last question, and then we'll wrap it up. Do counselors have to be certified? So, in order for our smoking cessation program to be viable, to be successful, must the counselors be certified, or is that an adjunct?
I don't know the answer to that question. It's an excellent question. We owe you to get that answer, and let me try to find out.
Thank you very much. Dr. Schroeder, this has been an amazing presentation. We're really so happy that you were able to join us today, and I'm really happy that the participants joined us as well. As you noted, with the large proportion of people who joined us today, I think this is a very important topic for us, for our patients, and has a reach that spans all of our patient populations, whether we're neonatal pediatric practitioners or adult practitioners, outpatient, inpatient. This is certainly one of those topics that spans the gamut of respiratory therapists. So thank you again.
Well, thank you.
For those of you watching this.
Thank you. It's just been such an honor. It's such an honor to work with respiratory therapists who, this isn't a glamorous thing to help smokers quit, but you're so well positioned. And I'm just so proud that so many of you have signed up for this, and I wish you Godspeed in carrying this out. And now I'll stop talking.
Thank you so much. For those of you who are watching this as a live presentation, please stay with us during the next brief pause for instructions on how to obtain your CRCE contact hour. If you are watching this program as an archive, this concludes our presentation.